This week, we talked to Essentia Health CEO Dr. David Herman about the challenges of rural healthcare and how he thinks they're about to change. This is Hospital Matters, a podcast from the Minnesota Hospital Association. We're having conversations about issues impacting hospitals, health systems, and patient care in Minnesota. I'm your host, Tim Nelson, and I'm joined in this episode by Dr. David Herman, CEO of Essentia Health. I started out by asking him what challenges rural providers are facing right now.
I am still excited about coming to work every day because I work with so many great colleagues who are committed to the mission of caring for people in some of the most sensitive and vulnerable times in their lives. And just having the opportunity as a physician to help patients and then to work alongside my colleagues that are truly motivated to do the same is an absolutely wonderful thing. Yet what I would say is a lot of the things that we've been talking about for the last 30, 40 years are finally coming to fruition. And our ability to work around the margins and be able to meet those challenges and still provide seamless care to our patients are becoming almost unsurmountable. The burden of illness in the population is increasing because we're aging as a population. And some of the diseases that when I started my healthcare career that were relatively acute diseases, we've had great success in turning them into chronic diseases. But this is not a healthcare system that's been designed to care for chronic disease. We are the best healthcare system in the world. If you have a car accident or you have a rare cancer, we are not if you have something that's common that requires prevention or something that requires the care of a chronic disease management program. So those are becoming the challenges going forward. Having the pleasure and honor to lead a healthcare system that's almost 85% rural, rural areas are disproportionately affected by the healthcare challenges. We're much more likely to be elderly. We're much more likely to have one or more chronic diseases, and we're much more likely to get our payment through government payment services, whether it's Medicare or Medicaid. So those unique challenges are making it very unique challenges for those of us at Essentia Health and my colleagues across the state of Minnesota.
So you talk about having a very large proportion of your system serving rural patients. What's Essentia doing to step up to that challenge?
First of all, we're committed to providing as much care close to home as we possibly can. The challenge that we're having is that we need to design a model of care that's actually sustainable to be able to do that in rural areas. And Tim, what I believe we need to do is redesign the system to be able to deliver that care. And that means that all of us are going to have to change. Those of us that are clinicians are going to have to change the way we provide our care. Does it need to be that face-to-face visit where somebody from Ely, Minnesota needs to spend almost 4 hours in a car for a 20-minute visit with their physician here in Duluth? Or can we design something different that allows them to have that visit from home and allow us to be able to provide that care? That's going to require a lot of thought, a lot of ingenuity, and I would say a lot of understanding from both the clinicians and the patients to be able to meet in the middle and see that new future. I think when those of us in healthcare, and I'm including those of us in healthcare as our patients, when we see the future, we like to see the past. I want to have the same services in Ely that I had 30 years ago, or the same services in my hometown, International Falls, than I had 30 years ago. That's likely not the future that we can go back to. Yet there are many things that we can do if we're willing to do things differently. And I'm excited about getting the right people around the table with the bright ideas to be able to do that. But that's going to require us doing things differently, trying some things differently, and we can't be afraid to fail. Because if we continue to push the system that we have right now, we already know that that's failing. I think that this could be a wonderful time in healthcare if we can do that. Yet it's still going to be challenging, particularly with the big, beautiful law. I wonder if there's anything that we can do in the short to intermediate term that could be enough that can prevent the adverse effects that this bill will have on the people we're privileged to serve.
You talked a little bit about this sweeping legislation passed in Washington. This bill looked particularly at rural healthcare and offered some financial assistance for that. What does the landscape look like now that this is passed?
Tim, I always like to start with the patients. And regardless if you're on Medicaid or you're on Medicare or have a commercial payer, this will decrease access to health care because there'll be about, from what we hear from the CBO, Congressional Budget Office, that about between now and 2034, about 13 million people will lose access to payment for health care. Those people will still be ill. They will still access the healthcare system because we are morally, ethically, and legally obligated to take care of these people. They will likely come more ill, require higher intensity of services, much more likely to be hospitalized, and all those services will need to be paid for in some way, shape, or form. We know that that payment can't come from Medicare patients. And for those of us that are in rural areas, in general in Minnesota, about 65% of the patients we're privileged to serve receive their payment either from Medicaid or Medicare. We can't shift the cost of that care to those two groups. That shift will have to go to those of us on commercial insurance. There is a limit to the ability for those of us on commercial insurance to absorb those costs and have our commercial rates affordable for us to have insurance. What this will mean is that many places that have access to healthcare now, particularly in rural areas, will not be able to have that access. That small clinic that's in that small community that's running on the thread right now. And Tim, I believe in Minnesota that 40% of our rural hospitals are either just break even or actually losing money already. This will tip them in a direction where they may not be sustainable in the future. So even if you are in that community that had that rural hospital and had commercial insurance, the loss of Medicaid may mean for you that that hospital or that clinic in that community is no longer there, and that access isn't there for you as well. I think we will see a lot of downstream effects from this. I don't think any of them will be good. There's been a lot of talk about fraud and abuse on this, and those of us in healthcare are certainly not in favor of any fraud and any abuse. Any fraud and any abuse takes dollars that need to go to the people we're privileged to serve that need them and is diverted away for some other purpose. But I don't believe that there's $1 trillion of fraud and abuse in the system right now, and nor do the people that I've talked to that are our congressional colleagues believe that as well. So I think we're going to be in a really tough spot here. I'm hoping it's just for a limited amount of time. I know that people that voted for the bill are now going back to the floor of the Senate and say we need to change some of this stuff. I'm hoping that through passing that bill, we can now sit down and have the conversation that I believe we needed to have at the beginning to say, how do we design a system that promotes the healthcare of all of us in America? And how do we do it in a fair and equitable manner that maintains access and great care for all of us? I think the other thing we need to recognize is the economic impacts, particularly for smaller communities. And many of the communities that we're privileged to serve, that hospital or that clinic is the largest employer within that community. If that hospital and clinic cannot maintain their viability and sustainability, and that ends up closing, you're losing more than just healthcare in that community. You're losing employment, you're losing economic stability. There's many different things, none of them good, that can happen to a community when healthcare access is reduced.
Following up on that, I think members of Congress are going to argue that they are at the same time offering some alternatives to unpaid care that could financially imperil hospitals, both in terms of urging more people into the private commercial market and also perhaps moving some people, if nothing else, out of the country. Undocumented immigrants will no longer be showing up at an emergency room and getting care without compensation. Sort of a bet that this will work out in the end. When you look at it, what do you think the odds of that are?
I would like to see the numbers on that. The challenge that I've had with it is I've heard the stories, but I haven't seen the numbers behind that. The reality is that many people who are on Medicaid right now are already employed, many of them with multiple jobs. They're likely working for an employer who, because of the way that their work is reimbursed, can't afford to provide them with commercial rate insurance. If you're making minimum wage or $14 an hour, you can't afford to pay for commercial insurance. You're already employed. Uh, will those people continue to be on Medicaid? The barriers, they may still be eligible for them, but in this bill, there's many barriers that keep them from accessing that insurance service. The need for them to reapply on a regular basis. I don't know about you, Tim, but it's hard enough to understand healthcare right now without having to, get proof from your employer that you're employed and all that stuff going forward. Uh, these barriers will likely, I believe, and there's good data out there from a variety of independent sources, exclude people because of the requirements and because of the barriers to apply, will exclude people who are eligible from accessing that payment for services. I would love to have a conversation where we sit down and we take a look at all the numbers. Those of us in healthcare are very comfortable looking at numbers because we have to match the revenues with the expenses each and every day. And as it becomes more and more difficult to be able to do that, our challenges increase. So let's have that conversation. Let's find out what that is. I had a conversation with one of my colleagues. They said, "Do you want a simple solution or do you want a complicated solution?" I said, "Neither. I want an elegant solution." What's the elegant solution that we can come together? We have a lot of people here in the United States that I believe are very motivated to make sure that people get what they need and get what they deserve. We need to have those conversations in order to come to that elegant solution to this. It will not be easy. It will not be simple. But I think the best part about that is that it won't leave people behind.
You touched a little bit on this earlier. I think there's some sentiment that this Medicaid phenomenon involves only part of Minnesota, a part that's more urban or diverse or concentrated in the Twin Cities, even though there are actually more Medicaid beneficiaries in Republican congressional districts than in Democratic districts. I think a lot of people may not think of this as something that really matters where they are among the people they see. What would you say to them?
Well, first of all, the statistics bust that myth. If you're in rural Minnesota, 20 to 25% of us in rural Minnesota, our care is paid for by Medicaid. 60% of nursing home residents in the state of Minnesota, their care is paid for by Medicaid. So there is no part of the state that's not touched by this. This is not something that just happens to others. These are things that happen to your friends and neighbors. Tim, you may be asking the question of, how did we get to this point? And I don't know the answer to that question. I think that's part of the conversation we need to have. Let's have a conversation that's based upon the realities, not based upon some of our biases, perhaps. Let's have a conversation that includes our neighbors that are on Medicaid that we regard as great neighbors in great parts of our community. And let's make sure they get the support and the care that they need. That will require a conversation. I don't believe that there's a soundbite that changes that. I don't believe that there's a billboard that changes that. I have reached out to our congressional colleagues and tried to have that conversation. We haven't been able to have that conversation. And until we have that conversation, I can't tell you what it will take to change the attitudes within the communities or change the minds of the decision makers and the policy makers going forward.
Well, I hope you come up with an imaginative and successful solution to that.
Well, we're going to continue to try, and we're going to continue to invite as many people under the tent as that are willing to show up and have the conversations that we need to have to do that. We in America have been in a difficult spots before. We have some of the smartest people, some of the most compassionate people in the world. I believe that if we focus our efforts in the right spots and at the right places and at the right time, we can come to this. My biggest concern, though, Tim, is that what will drive us to that solution will be the people that are hurt and left behind that drive the conversation, rather than the ability to look forward and see what we can imagine and what we want going forward.
Thanks so much.
Thank you.
Again, that's Dr. David Herman, CEO of Duluth-based Essentia Health. I'm Tim Nelson, and you've been listening to Hospital Matters from the Minnesota Hospital Association. Join us next time for another look at issues impacting hospitals, health systems, and patient care in Minnesota. Thanks for listening.